So thank for the kind words to the presidents, the chairs, and thanks to my good friend, Professor Kotis, for the invitation. I'm trying to advance my presentation, but I seem to have a problem here. All right, so we moved a bit fast. So as you know, and as we have already discussed, the diagnosis of CKD is very crucial. It's not very difficult. You just need to assess kidney function with eGFR and kidney damage with albuminuria. And the actual definition of CKD has not changed for quite some time now. So this is an important thing for everybody to consider and for PCPs and internists around the world to do early detection of CKD. So if you do things properly, you will end up with 800 million people with CKD, that is 12% of the global population. And among them, a very small fragment, 4 million, are on kidney replacement therapy. So among different mechanisms that we can actually detect, hemodynamic mechanisms, metabolic mechanisms, there has been a lot of discussion, at least for 3 decades, on microinflammation and fibrosis in the renal tissue. However, different compounds that were about to target these mechanisms were not successful, and they didn't move further than phase 2 clinical trials. MRAs, non-steroidal MRAs, do have hemodynamic properties, but also act, as I will explain you in a few seconds, on inflammatory and fibrotic pathways. So this is a kind of a new dimension of what we can do for diabetic kidney disease. So you all know that the healthy kidney, as we age, loses about 1 or 1.5 mL per minute. And if you have diabetes, this is not good. Even if you have normal albuminuria, you will lose about 3.5 mL per minute. If you have macroalbuminuria and you do everything perfectly, then you will lose about 5 to 6 mL per minute. That means that you need to have your blood pressure at 120, lipids, blood sugar controlled, and full dose of ACEs or ARBs. If you don't do that, or if your albuminuria is on the nephrotic proteinuria range, then you will have a much higher GFR decline of around 10 mL per minute. So the thing is that we have here, as I'll tell you in a minute, a large unmet need. Another dimension that we have to consider and we have to focus on, we nephrologists do talk about that a lot over the recent years, is what is going on cardiovascular disease. So as you can see here, both GFR reduction and ACR, albuminuria increase from a very, very low level are independently associated with cardiovascular events and cardiovascular mortality. So, I'm sorry about that. So it has been very well established that if you have a combination of chronic kidney disease and diabetes, then the actual risk for cardiovascular disease is multiplied, and it's more than 6 times higher compared to the people of the same age that don't have any of these two conditions. So, what were our pre-existing and what are the existing treatment choices for diabetic kidney disease? So this is a very, very old story, but has not, I mean, it had for a very much time, not a lot of news, no good news. So since 2001, with irbesartan and losartan coming out in renal and IDNT studies, for almost 20 years, we have absolutely no treatment in the major problem of nephrology, no new chronic kidney disease specific therapy. And then we had some very, very important improvements. So if you want to see here what happened with losartan and irbesartan, and we have been using these drugs forever, it's a very nice thing that they reduce the risk, but the risk reduction is about 16 or 20%, and we still have a very high residual risk. Yes, we can see there in gray. So what happens here is very simple. This is the reason why dialysis units are full, are expanding, and the patients with end-stage kidney disease are increasing over the years. Then there was a very nice surprise, at least for us nephrologists. There were a lot of studies on blood glucose control that had used ACR as a secondary outcome. And there was a very clear notion there. We summarized that a few years ago. SGLT2s were able to reduce albuminuria, and this was dependent on the initial value of albuminuria. And this was a very strong effect, a potent effect of around 30 to 40%. So from a 30% reduction, you would expect a 15% reduction in major outcomes. SGLT2s, however, were much better than that. So the reduction in the combined heart renal endpoints was not 15%. It was much better than ACEs and ARBs. It was 30 or 40 or even 45% in some studies. And these are the two very important studies in diabetic nephropathy. We have EMBA-Kidney now showing again that these drugs are working very well. However, still, we have people with diabetic kidney disease. You still have a lot of residual risk, and we still need to do a lot of things. So this is how we come to MRAs, and their story was developing in parallel to the SGLT2s. And what I'm going to tell you is that this is not something that came as a surprise. This is a very old story. So you all know what are the functions of aldosterone. If you have an increase in potassium, aldosterone is increasing, and it gets rid of potassium in the distal nephron. If you have hypovolemia, you get renin increase and angiotensin increase, and then you get aldosterone increase. And what happens here is, again, secretion of potassium, but with retention of sodium. So aldosterone is a very important hormone. It's the hormone, the main hormone that we have in order to secrete potassium. This is what our body has for hundreds of thousands of years. But at the same time, it's the most potent mechanism for us to avoid hypovolemia and pre-renal acute kidney injury, one of the main mechanisms. However, as happened with a lot of important critical body systems, the MR receptor, the receptor of aldosterone, is involved in a lot of other actions. So the basic physiological action, this is potassium and sodium exchange in the distal nephron, is coupled by different actions. So when you have excessive activation of the MR as we age, or when you have different cofactors linked to the MR after the activation from aldosterone or cortisol, you can have some very bad results in the kidneys, as you can see here, mesangial cell proliferation and macrophage infiltration and podocyte damage. And this is what happens to glomeruli, but you can have also interstitial fibrosis. So what is there, and it's very helpful for us in order to be healthy, to avoid disease over time, it can be maladaptive, as happens with a lot of other systems, the renin-angiotensin system, the endothelial system, whatever. And there's another important issue that we tend to forget. One of the major problems with the use of ACEs and ARBs, and this is very well documented in hundreds of studies for at least 2 decades, is the phenomenon of aldosterone escape. So we have the escape of angiotensin 2 in the chronically treated patients with a RAS blocker, but we have the escape of aldosterone. So what happens is that we can have angiotensin II through different pathways so that aldosterone is again elevated. So one of the main problems, perhaps the main problems, not allowing the ACE and ARB drug compounds to offer you a lot of nephroprotection is the phenomenon of aldosterone escape. Aldosterone is going up again. So if you see what is actually happening in major studies we had in previous decades, trying to combine different parts of the system, this is what happened with the Nephron D study, and this is exactly what happened with the Altitude study. When you combine losartan and lisinopril, you don't win, you don't get a lot of extra benefit, and actually have problems of acute kidney injury and hyperkalemia. And with two major outcome trials being stopped early due to harm, due to problems, this combination is not recommended and not available. You should not do it. However, there are again a lot of important studies. This is a slide I used more or less 14 years ago in one of my talks that examined aldosterone blockade in chronic kidney disease based on the phenomenon of aldosterone escape I was telling you about. So one of the most famous studies, this is the famous studies, the most famous studies, it appeared almost 20 years ago from an Australian group led by two Greek Australians here, was the combination of ramipril with irbesartan. This is what you get. And then there's a combination of ramipril and spironolactone and a triple combination. So what you can see here is that if you combine ramipril and spironolactone, irbesartan is absolutely not necessary. So spironolactone does all the work, and there is a very potent decrease in albuminuria of about 50%. So this is one of the most famous studies, the first one. And there are a lot of studies like that. So if you actually combine the studies, you do have at least another 30% reduction of albuminuria. So this is a very important, known for at least 2 decades pathway. The problem is that spironolactone is a very strong, a very potent inhibitor of anything that happens through the MR receptor. So if you use it, we all know that, and we all use it, you cannot secrete potassium. So the problem is that potassium is up, and this is not something that you can easily deal with in patients with chronic kidney disease. So this is the main reason why this potent mechanism of nephroprotection was never actually applied in clinical practice, or was applied by a few of us that knew what was happening with extreme care in a few patients. So, anything else? Very important information. There are a few studies on heart failure showing that even in patients with heart failure without albuminuria, if you check what happened to people with chronic kidney disease, you would see that the protective effect of aldosterone blocker on people with heart failure was also evident in those that had also chronic kidney disease. And there are also two studies. This is a Japanese one, and there is a Chinese one. And there are also two studies running, an American one and a European one with a lot of patients, showing that if you actually test spironolactone in hemodialysis, there is a huge benefit in mortality. And as you know, this is very important for our patients. So we have two major studies now actually checking that. So in addition to the renal protective effects, there are important also mortality benefits that is actually established in different categories of patients, but these drugs are only used in heart failure with reduced ejection fraction. Period. This is the only actual indication for non-steroidal MRAs until now. So, what has actually happened? A few drug companies, and the first one was Bayer, actually saw that this is a very, very potent pathway and spent a lot of money and a lot of effort. They tested thousands of compounds. Rumor has it that Finerenone was a compound selected among at least 10,000 other compounds to produce a drug that can have the benefits of MR blockade without the problems of MR blockade. And this is what happened. And now we don't only have Finerenone, we have at least 5 and more to come non-steroidal MRAs. If you see the steroidal MRA structure, you can easily see that the basic steroidal hexagon here is there. So the structure is extremely similar to the steroidal hormones. Non-steroidal MRAs are different, are totally different. And this actually is coming with several different properties. So the potency, the affinity to the MR receptor, and the selectivity to the MR receptor are very high. And the actual important fact is that spironolactone has a kidney to heart tissue distribution of 6:1, eplerenone of 3:1, and Finerenone has a kidney heart distribution of 1:1. So only from the tissue distribution you can expect a 5 to 6 times lower problems with regards to potassium. So the other issue here is that the way this actual drug works, and most of the other compounds, is that they are actually able to inhibit the bad actions, anti-inflammatory and antifibrotic actions, without interfering a lot with the physiological action. So they are interfering here, but much less, if I may. So that's why they don't reduce blood pressure that much, and they don't increase potassium that much. So these two actions come together. So they are very milder, if I may say, blood pressure lowering drugs, and there are milder potassium increases. So why is this happening? This happens because of an important story here. So the MR receptor is a nuclear receptor. It's located in the nucleus of the cells of the connective tubule and the other parts of the distal nephron. So the actual things that happen after MR activation depends a lot on the ligand that is coming in and the cofactors that are recruited after the ligand is attached. So what happens here, Finerenone is an inverse agonist, so it inhibits cofactor binding both in the presence or the absence of aldosterone, whereas Spiro and eplerenone are partial agonistic cofactor recruitment compounds. So if aldosterone is here, they block it. But if aldosterone is not there, they actually act on the MR receptor. And the second thing is that Finerenone blocks different cofactors to be recruited in the MR. So you have a different tissue distribution and a different cofactor recruitment. So it seems that Finerenone suppresses a lot of the bad actions. And this is what I just told you. If you see this figure here, this is what it tells you. So the complex that forms after the spironolactone binding and Finerenone binding is much different. So you have different gene transcription. So you have a gene transcription profile that includes less pro-inflammatory and pro-fibrotic genes. So what happened with trials? And I have a few minutes, but I won't be long. So these are the actual very first trial. I was on the safety committee on this trial. There is a clear dose-dependent reduction of albuminuria up to 40% without significant hemodynamic changes, no GFR drop, and without significant potassium increases. So everybody thought this would not be working in albuminuria, but it is. And exactly the same thing happens with esaxerenone, and exactly the same thing happens with apararenone, of strong albuminuria reductions on a lot of patients. So these are the two other non-steroidal MRAs. I don't think they will be coming in Greece anytime soon, but that's for you to know. So we just now had a very, very important addition. It's not just now, it's about a couple of years now. We have two major trials that you all know, the Figaro and Fidelio trial. The Fidelio had somehow patients with more advanced kidney disease and a kidney primary outcome. The Figaro had a cardiovascular composite. So these were twin trials to see if Finerenone will offer renal and cardiovascular protection in patients with diabetic kidney disease. And this is actually what happened. So this is the primary endpoint in Fidelio, a renal endpoint, very clear benefit. This is the secondary endpoint in Fidelio, cardiovascular endpoint, very clear benefit. The actual curves separate very early. And I'm just going to jump a few slides. This is the Figaro primary outcome, a cardiovascular endpoint, and this is the Figaro renal outcome. So overall, two trials, 4 outcomes, all clearly beneficial with Finerenone. And the important thing here is that end-stage kidney disease was reduced a lot. So if you try to see what happened to the separate outcomes, this is the fidelity analysis combining the two effects. This is what mostly is the actual effect of the drug. So reduction of heart failure, reduction of cardiovascular death does not affect MIs and strokes, exactly similar to SGLT2s. And this is the renal outcome analysis, where you can see that it reduces by the exact same amount the renal outcomes, all renal outcomes involved. So this is very important. And last but not least, this is a very important analysis. So this is the on-treatment mortality analysis. The two studies were not powered for mortality, and there was not any expectation to reduce mortality in such a short time frame. But again, if you check it carefully, there is a 20% reduction in all-cause death within 3.5 years, which is extremely important. The other thing that most of us ask, and this is again very important, is what happened if you combine them with SGLT2s. So you have a very beneficial category and another very beneficial category. So what you expect is to have the benefit being reduced when you combine both of them. So what happens here is exactly the opposite. So the benefit is not reduced. The benefit seems to be higher. So it seems to be some additive effect, synergistic effect, and this may be related to the fact that SGLT2s protect against the slight hyperkalemia, so that patients can tolerate Finerenone better. So I don't have the time, and I don't want to actually delay a lot. I will only show you this slide on hyperkalemia. So when you give an MRA antagonist, you expect a lot of hyperkalemia, but actually what happened, the termination due to hyperkalemia in Fidelio DKD and Figaro DKD was much lower than what happened in the Douglas blockade studies of the previous decade. So it's very clear that the drug is not as dangerous as we thought it was. So I'm gonna end with 2 slides on treatment recommendation, and these are the most recent recommendations. So this is the guidelines of the hypertension community, the European Society of Hypertension. This is regularly the most cited document in the world. So what happens here, among different things, the non-steroidal MRA Finerenone is recommended in patients with CKD and albuminuria associated with type 2 diabetes mellitus down to a GFR of 25. So the recommendation is exactly the same with the current indication that we have in many countries, including our country today, a very simple and clear. You need to have serum potassium below 5 in order to start the drug. And the other is a document that we wrote on behalf of the European Renal Best Practice Guidelines. So a lot of the things I told you, it's in this document after a systematic review of what happens, and we say exactly the same thing. CKD with micro or macroalbuminuria, you should have an ACE or an ARB first. You should have blood pressure control, and then use both an SGLT2 inhibitor and for patients with type 2 diabetes, a non-steroidal MRA that is available. This is Finerenone only. So I'm sorry about my last slide. That's a small mistake. So my conclusions are very obvious. MR activation is a very important factor for inflammation and fibrosis in kidneys, the heart. Aldosterone escape is a factor that cancels a lot of the benefits of ACEs and ARBs. And now we have two sets of studies. We have the old studies with reduction of albuminuria with any MRA, but we have two major phase 3 clinical trials with heart renal outcomes suggesting that Finerenone can reduce heart renal endpoints and cardiovascular endpoints in patients with diabetic nephropathy, and that is why now there is a class 1A recommendation for Finerenone. And that is my last slide. Thank you very much for your attention.